Despite the overwhelming amount of research pouring into glioblastoma practice, only a handful discoveries have actually made it through to our daily clinical practice. And if you are preparing for neurosurgery exams, you need to know the key evidence treatments that have truly changed how we approach this aggressive disease. Today, I will share with you 7 advancements in glioblastoma management that not just clinically significant but also exam essentials. Let's start by talking about the evidence-based treatment. As we know, according to Oxford Center of Evidence-Based Medicine, we're starting by level 5, very low level expert opinion, and then go up with a case series in level 4, and then systematic review of case controls studies, and then systematic reviews of cohort studies, and finally systematic review of randomized control studies. This is the evidence based on Oxford Center. Stupp protocol. Let's start with the Stupp protocol, the cornerstone of glioblastoma treatment. The Stupp protocol published in 2005, and this is a landmark paper that established the combination of radiotherapy and chemotherapy as the gold standard of the maximum surgical resection. It significantly improved the overall survival and remains the foundation of our approach today. As we can see in this diagram, there is a maximum surgical resection. This is the starting of the Stupp protocol. They have 2 stages. One stage is radiotherapy and concomitant temozolomide, where the radiotherapy is total 60 gray over 6 weeks, with 2 gray every day from Monday to Friday, with a weekend off that equal 30 fractions. At the same time, we have concomitant phase, which temozolomide 75 mg daily for 6 weeks. After that, this initial 6 weeks finished, we go to the monotherapy, where the temozolomide is 150 over to 20 mg per meter square, each first 5 days of each 28 days. So for a total of 6 cycles, you have the temozolomide. Now let's move to the extent of resection, or what we call RANO criteria. So this is really interesting. Resections played a crucial role in patient outcome. How much you left of the tumors, and RANO, or Response Assessment in Neuro-Oncology group, classify the resections based on a simple idea between the contrast enhancing tumor in T1, how much we remove from this blue part we can see, and also how much non-contrast enhancing but hyper intense in the FLAIR study, which is, we believe it's representative of glioblastoma infiltrative tissues. This systematic approach guides through the surgical decision making and the key concept in both exams and practice. And based on that, we have class 1, which is supra maximum contrast enhancing resection, which is when we leave 0 centimeters cubic of contrast enhancing and less than 5 cubic centimeters of non-contrast enhancing in the imaging study postoperatively. And that median over survivals is 24 months, which is 2 years. Of course, that can lead to neurological deficits in some cases. The other class is a maximum surgical resection, so contrast enhancing, which is where we have less than 0 and more than 5 centimeters of non-contrast and 0 of cubic centimeters of contrast enhancing. If we less than 1 centimeters, that consider maximum surgical resection 2B. That lead to 19th month of median overall survival. Moving to the submaximal contrast enhancing resection, we will leave less than 5 cubic centimeters or more than 5 cubic centimeters of contrast enhancing in the T1 postoperatively. And that will lead to 15th, the gold standard. Usually we say to our patients, the 15th month overall survival. And the class 4 is biopsy, and there is no reduction of tumor volume exactly. And this will give a 10 month if the patient had a chemoradiotherapy. Moving now to another segment, which is the 5-ALA, the 5-aminolevulinic acid. The 5-ALA fluorescence-guided surgical techniques has lighting up the tumor cells during surgery allowing precise resections. Let's talk about the mechanism of 5-ALA. So 5-ALA taken preoperatively with a patient with a suspected glioblastoma, that crossing the blood-brain barrier and then going to the mitochondria, where the 5-ALA become a protoporphyrin 9 and protoporphyrin 9. And protoporphyrin 9 is usually, under normal circumstances, degraded further by ferrochelatase enzyme to heme, while in glioblastoma, this enzyme is less effective. That leading to further accumulations of protoporphyrin 9 inside mitochondria, inside the glioma cells. And this substance is able to emit a bright pink fluorescence when exposed to the blue light microscope with wavelength 405 to 633 nanometers wavelength. That allowing the tumors to showing as a bright pink and guiding the surgical resection. The 5-ALA is an oral reconstitute of 50 ml of drinking waters, usually 1.5 gram powder. We reconstitute in 50 ml of drinking water, and in the oral solution become 30 milligram per ml, and we give an oral administration. The dosage, which is 20 milligram per kg. And usually it's better to have 2 to 4 hours per surgery. You need to know also the side effects, but this is outside the scope of this presentation. So what's really the evidence we based on in the 5-ALA? There's a randomized controlled trial, fluorescent guiding surgery with a 5-aminolevulinic acid. We're using the 5-ALA, making the contrast enhancing resections completed in 65% of the patients, comparing to 36% of the patients using white light. And that allowing a higher 6-month progression-free survival. Okay, moving to awake craniotomy. Awake craniotomy offers significant advantages over general anesthesia, particularly for glioblastoma near eloquent brain. And this is allow real-time patient interaction during surgery, enabling surgeon to map and preserve the critical functions like speech and movement. This approach helps to maximize the tumor resection with minimizing the post-operative neurological deficits, ultimately improving the outcome. However, it has drawbacks: a very careful patient selection, and also potential discomfort and anxiety during surgery, and also longer operative times in some cases. Moving now to intraoperative MRI, or in short, iMRI. Allowing real-time imaging during surgery, enhancing the surgeon abilities to achieve the maximal resections. Studies confirm its efficacy, increasing the rate of complete resections, making it a valuable additions. I believe that the drawbacks is it's not available in all hospitals. It's need a very strong infrastructure and investment to allow the MRI to be installed in one of the neurosurgical theater. This Sifnet in 2011 talking about intraoperative MRI guidance and extensive resection, and he said that more patients with intraoperative had a complete tumor resection than the control group, and we see that the post-operative rate of neurological deficits did not differ between the patients. Moving to Bevacizumab drugs, which is anti-VEGF therapy that target the tumor blood supply. VEGF is responsible for the vascular endothelial growth factor, is responsible for stimulating the endothelial cell proliferation and migration in glioblastoma microenvironment. And bevacizumab reduce regression of this existing microvessels and inhibit growing of new blood vessels. And it acts mimicking as a dexamethasone, but in more potent effect. As we can see, the overall survivals are increased by few months when using bevacizumab. That's why it's FDA approved in the United States. However, in European Medicine Agency and UK NICE guidance have not been proven as cost effectiveness treatment. Moving to the last advancement in glioblastoma, which is the tumor treating fields. As we know, it's a novel, non-invasive modality by applying mild electric fields with the patients, disturbed cancer cell divisions, and usually combined with the temozolomide. There's a significant improvement in progression-free survival, and it's a game-changing in glioblastoma. There is currently a trial in the UK running to see the effectiveness and to prove that to be included in the NICE guidelines. The effect of tumor treating fields plus a temozolomide versus temozolomide alone. In survival, we can see that the progression-free survival increased by 2.7 months, and also the overall survival improved by 4.9 months. Thank you. These 7 advancements representing the cutting edge of the evidence-based glioblastoma treatment. Mastering these is just not about you passing your exam, it's also about understanding the progress we have made in battling one of the most challenging diseases in neurosurgery. If you'd like a copy of these slides, sent straight away to your email. Simply scan your QR code here and it will take you a quick feedback, completed in just a minute, and the slides will be in their way to your inbox. Thank you.